Hey, wonderful viewers! Welcome back to our channel, where we delve into the fascinating world of medical knowledge. Today, our focus is on an intriguing and complex condition known as systemic lupus erythematosus, or SLE. Systemic lupus erythematosus, SLE, is a chronic autoimmune disease characterized by multisystem manifestations. In Australia, SLE is more common and more severe in Indigenous Australians and descendants from Southeast Asia. 9 times more common in females. Most commonly affects women of childbearing age. Before puberty, the proportion of affected males is higher. The onset of SLE is rare before the age of 5 and uncommon before adolescence. When SLE appears before the age of 18 is called pediatric SLE, juvenile SLE, and childhood-onset SLE. SLE has a relapsing and remitting nature where patients experience episodes of symptom exacerbation interspersed with periods of relatively low disease activity. The etiology of systemic lupus erythematosus, SLE, is complex and involves a combination of inherited and environmental factors. This abnormal immune response is thought to be influenced by various inherited risk factors and random environmental triggers. SLE can be initiated by factors such as hormonal imbalances during puberty, exposure to stress, and environmental elements like sunlight. Additionally, viral infections, certain medications, such as isoniazid, hydralazine, procainamide, and anti-seizure medications, as well as vitamin D deficiency, have been identified as potential triggers for SLE. Exposure to silica dust and cigarette smoking may elevate the risk of developing SLE, while estrogen use in postmenopausal women has been associated with an increased susceptibility to the disease. Photosensitivity is recognized as a clear precipitant of skin manifestations in SLE, emphasizing the impact of environmental factors. On the other hand, breastfeeding has been linked to a decreased risk of developing SLE. Children inherit certain genetic factors from their parents that may contribute to the predisposition for SLE. Although these genetic factors are not fully understood and there is currently no available genetic testing or prenatal diagnosis for SLE, clinical features of systemic lupus erythematosus include a wide array of features. Constitutional manifestations such as malaise, fatigue, fever, and weight loss. They are, however, nonspecific. Fibromyalgia is also commonly observed in patients with SLE. In musculoskeletal system, the most common presentation is asymmetrical polyarthritis affecting hands, wrists, and knees. Also arthralgia and myalgia, in contrast to rheumatoid arthritis, SLE arthritis, or arthralgia may be asymmetrical, with pain that is disproportionate to swelling. They are rarely erosive or deforming. Arthritis of the proximal interphalangeal, PIP, and metacarpophalangeal, MCP, joints of the hands, as well as the wrists, is the most common musculoskeletal finding in SLE. Charcot-arthropathy is the term used to describe the non-erosive hand deformities due to chronic arthritis and tendinitis. Cutaneous manifestations. The most classical forms associated with SLE are photosensitivity, acute malar, and chronic discoid lupus erythematosus rash. Acute malar rash is a slightly raised erythematous rash of the face, particularly cheeks, and nose, with nasolabial sparing, known as the butterfly rash. A worsening of the rash usually accompanies a flare of systemic disease. Discoid rash is characterized by slightly raised, scaly lesions that have the potential to scar. They can be found commonly on the scalp and face, and less commonly over the limbs and trunk. Discoid lupus is a chronic lupus rash. Discoid lesions often also develop in sun-exposed areas, but are plaque-like, with follicular plugging and scarring. They may be part of systemic lupus or may represent discoid lupus without organ involvement, which is a separate. Photosensitivity rash in SLE may be either acute or chronic. Is often macular or diffusely erythematous in sun-exposed areas of the face, arms, or hands, and generally persists for more than 1 to 2 days. Subacute cutaneous lupus is a characteristic lesion appearance is an annular or psoriasiform patch with crusted margins. Lesions often occur on the limbs or torso in sun-exposed areas. Half of the patients with this condition will have it in isolation without systemic lupus. Common skin manifestation in drug-induced lupus. Alopecia is an often less specific cutaneous feature of SLE. It often affects the temporal regions or creates a patchy pattern of hair loss. Other cutaneous manifestations related to, but not specific to, SLE include the following: Raynaud phenomenon, livedo reticularis, paniculitis, lupus profundus, bullous lesions, vasculitic purpura, telangiectasias, urticaria. Renal. The kidney is the most commonly involved visceral organ in SLE. Glomerular disease usually develops within the first few years of SLE onset and is often asymptomatic. Lupus nephritis is one of the more serious manifestations. Definitive diagnosis can be obtained by renal biopsy, but the presence of glomerular hematuria, proteinuria, or casts are the key features. Acute kidney injury or chronic kidney disease may cause symptoms related to uremia and fluid overload. Acute nephritic disease may manifest as hypertension and hematuria. Nephrotic syndrome may cause edema, weight gain, or hyperlipidemia. Hematologic anemia is due to chronic inflammation, but sometimes autoimmune hemolytic anemia. Leukopenia, more specifically, lymphopenia, are common in SLE. Thrombocytopenia may also be a recurring feature. A history of recurrent early miscarriages or a single late pregnancy loss may be clues to lupus or isolated antiphospholipid antibody syndrome. Neuropsychiatric features. The American College of Rheumatology, ACR, recommends 19 neuropsychiatric syndromes in SLE as shown below. Seizures related to SLE may be generalized or partial and may precipitate status epilepticus. Psychosis may manifest as paranoia or hallucinations. Delirium represents a spectrum of fluctuating altered consciousness, characteristic of SLE. Pulmonary manifestations include pleurisy, exudative pleural effusion, pneumonitis, pulmonary hypertension, and interstitial lung disease. Pulmonary embolism, lupus pneumonitis, chronic lupus interstitial lung disease, pulmonary hypertension, complement-mediated pulmonary leukoaggregation, or infection may be related to lupus disease. Hemoptysis, due to diffuse alveolar hemorrhage, a rare, acute, life-threatening pulmonary complication of SLE. Gastrointestinal manifestations. They are less common than adverse effects of medication, nonspecific complaints, and infectious causes due to immunosuppression. Peptic ulcer disease is a common complication, especially in SLE patients treated with NSAIDs and steroids. Abdominal pain may be related to active lupus, including peritonitis, pancreatitis, mesenteric vasculitis, and bowel infarction. Rarely, lupus enteritis may be the initial manifestation of SLE. Cardiac manifestations. Pericarditis is the most common cardiac feature. Myocarditis may occur in SLE with heart failure symptoms. Coronary vasculitis rarely occurs. Liebman-Sachs endocarditis is non-infectious, but may manifest as symptoms similar to those of infective endocarditis. Can present as systolic murmurs, digital infarcts, and splinter hemorrhages. More frequently, SLE is linked to accelerated ischemic coronary artery disease. Almost all patients have antinuclear antibodies at diagnosis. However, they are nonspecific and present in a little. More specific for lupus is the presence of anti-double-stranded DNA antibodies. Anti-Smith antibodies are uncommon but specific for lupus and associated with nephritis and cytopenias. Antiphospholipid antibodies can also be found and are classically associated with an elevated risk of thrombosis and miscarriage. Antibodies against the extractable nuclear antigens Rho, SSA, LA, SSB, and ribonuclear protein are common but nonspecific in the diagnosis of lupus. The Systemic Lupus Erythematosus International Collaborating Clinics, SLIC, group criteria. Diagnosis of definitive SLE requires 4 or more criteria, with at least one clinical and one laboratory finding. In 2019, the European League Against Rheumatism, EULAR, and the American College of Rheumatology, ACR, published criteria for the classification of SLE. The classification requires an antinuclear antibody, ANA, titer of at least 1 hour 80 minutes on Hep2 cells or an equivalent positive test at least once, otherwise, the patient is considered not to have SLE. If it is present, 22 classification criteria are considered: comprising 7 clinical domains and 3 immunologic domains. Each criterion is assigned points, ranging from 2 to 10. Patients with at least one clinical criterion and 10 or more points are classified as having SLE. The disease may begin slowly with new symptoms appearing over several weeks, months, or even years. In children, SLE has a more severe course in that children more often show several features of inflammation due to SLE at any given time. Children also have kidney and brain disease with SLE more often than adults. Raynaud pleuritis and Zika were twice as common in adults as in children and adolescents. The classic presentation of a triad of fever, joint pain, and rash in a woman of childbearing age should prompt investigation into the diagnosis of SLE. Laboratory studies. Complete blood count can show leukopenia, anemia, and thrombocytopenia. ESR and CRP. The ESR elevation level could differ from the typical CRP level in SLE flares. CRP levels change more acutely, and the ESR lags behind disease changes. CRP can be normal in SLE, while ESR is elevated. Complement levels, decreased. Liver function tests, mildly elevated in acute SLE or response to therapies. Creatine kinase assay, elevated in myositis. Spot protein/spot creatinine ratio, quantify proteinuria. Imaging. The most common radiographic anomalies in SLE are periarticular osteopenia and soft tissue swelling without erosions. Chest imaging includes radiography and CT scanning used to monitor interstitial lung disease and to assess for pneumonitis, pulmonary emboli, and alveolar hemorrhage. Echocardiography is used to assess for pericardial effusion, pulmonary hypertension, or Liebman-Sachs endocarditis. Brain MRI or MRA is used to evaluate for CNS lupus white matter changes, vasculitis, or stroke. Biopsy. Renal biopsy for all cases of active, previously untreated lupus nephritis, unless contraindicated. Used to confirm the presence of lupus nephritis, to aid in the classification of lupus nephritis, and to guide therapeutic decisions. Skin biopsies help in diagnosing SLE or unusual rashes. Management of SLE. The management of SLE includes 3 goals: preventing flares and their symptomatic impact, reducing chronic accumulation of organ damage, minimizing toxicity from immunosuppression. All patients should minimize sun exposure and use hydroxychloroquine unless contraindicated. Resistant to these measures, antiproliferative immunosuppressants and corticosteroids are effective. The choice of antiproliferative is influenced by the organ involved. European League Against Rheumatism, EULR, definitions of treatment goals in SLE are as follows. Complete remission, absence of clinical activity with no use of glucocorticoids or immunosuppressive drugs. Low disease activity, SLEDAI score less than or equal to 3 with antimalarial therapy, or SLEDAI less than or equal to 4, PGA less than or equal to 1 with glucocorticoids at less than or equal to 7.5 mg of prednisone equivalent and well-tolerated immunosuppressive agents. Partial renal remission, reduction in proteinuria by greater than or equal to 50% to subnephrotic levels and serum creatinine within 10% from baseline by 6 to 12 months. Complete renal remission, proteinuria less than 500 mg per 24 hours and serum creatinine within 10% from baseline. EULR-specific medication recommendations. Hydroxychloroquine is recommended for all patients with SLE. Glucocorticoids can provide rapid symptom relief, but the medium to long-term aim should be to minimize the daily dose to less than or equal to 7.5 mg per day prednisone equivalent or to discontinue them. Subsequent initiation of immunosuppressive drugs facilitates more rapid tapering of glucocorticoids and may prevent disease flares. The choice of agent depends on prevailing disease manifestations, patient age and childbearing potential, safety concerns, and cost. Adjunctive methods include sunscreens, SPF 50+, should be used as well as avoiding exposure during peak hours. Smoking cessation may help with treatment-resistant skin lesions. Vitamin D supplementation may decrease disease activity and improve fatigue. Nonsteroidal anti-inflammatory drugs. NSAIDs are effective for symptom relief in lupus-associated arthritis and myalgias. In the presence of lupus nephritis, they increase the risk of acute kidney injury and death when used in patients with end-stage kidney disease. Aspirin is widely used in children with elevated antiphospholipid antibodies to prevent thrombosis. Hydroxychloroquine should be used in all patients with lupus unless contraindicated. Hydroxychloroquine is useful in both cutaneous and systemic lupus. Around half the patients need a higher dose. In addition to improving skin symptoms, hydroxychloroquine reduces flares of systemic lupus and lupus nephritis. It also lowers cholesterol and thromboembolic risk in patients with antiphospholipid antibodies. Consequently, sustained hydroxychloroquine therapy minimizes accrual of organ damage and glucocorticoid-induced osteoporosis, and improves overall survival. The major complications of hydroxychloroquine therapy are ocular. Transient and reversible corneal deposits occur with a risk of irreversible retinopathy, which manifests as visual disturbances, photophobia, or light flashes. Less common adverse effects include cardiac, cutaneous, and neuropsychiatric manifestations. Monitor baseline fundus exam of the eye, then annual screening after 5 years of treatment. Hydroxychloroquine is safe to use in pregnancy and should be continued. Almost all patients will be treated with corticosteroids at some point. They are effective in controlling systemic lupus, but their sustained use is limited by substantial toxicity. Corticosteroids are used transiently to control systemic disease flares or when disease activity cannot be controlled by other drugs alone. Due to toxicity, they should never be used on their own. The toxicity of corticosteroids needs to be balanced against the threat of organ injury if they are not used. For mild disease, lower doses are often sufficient. High doses are typically reserved for debilitating or life-threatening involvement, such as lupus nephritis or neuropsychiatric lupus. Once disease remission is achieved, the dose should be tapered. For cutaneous lesions, topical corticosteroids are the mainstay of treatment. Higher potency creams are better. However, they increase the risks of telangiectasia and skin atrophy. For antiproliferative immunosuppressants are primarily used in systemic lupus, azathioprine, methotrexate and mycophenolate, cyclophosphamide. For non-renal manifestations such as arthritis and rash, where hydroxychloroquine or topical corticosteroids are insufficient, methotrexate is effective. While evidence is stronger for methotrexate, azathioprine is also useful and has the benefit of being safe in pregnancy. Thiopurine methyltransferase activity should be tested before azathioprine is used to avoid bone marrow suppression in patients with a deficiency. Mycophenolate is effective in non-renal disease that is refractory to corticosteroids and is superior to azathioprine. However, it is contraindicated in pregnancy. For systemic lupus with kidney involvement, mycophenolate is superior to azathioprine, so it is first-line maintenance therapy when tolerated. Cyclophosphamide can be considered in organ-threatening diseases, especially renal, cardiopulmonary, or neuropsychiatric, and as rescue therapy in patients with non-major organ manifestations refractory to other agents, biologic agents. Rituximab may be considered in patients with severe renal or extrarenal, mainly hematologic and neuropsychiatric, disease refractory to multiple other agents. Belimumab in patients with extrarenal disease inadequately controlled by first-line treatments, for specific SLE manifestations. For skin disease, topical agents, glucocorticoids and/or calcineurin inhibitors, and preferably hydroxychloroquine. Neuropsychiatric disease, steroids and/or immunosuppressive agents. If antiphospholipid antibodies are present, anticoagulant/antithrombotic treatment. Hematologic disease, significant lupus thrombocytopenia, moderate to high doses of glucocorticoids in combination with a steroid-sparing immunosuppressive agent, azathioprine, MMF, or cyclosporin. Intravenous immunoglobulin, IVIG, may be considered in the acute phase. Lupus nephritis treatment consists of an initial induction phase followed by a more prolonged maintenance phase. Mycophenolate and cyclophosphamide are choices for induction treatment. Mycophenolate plus high-dose cyclophosphamide may be considered for patients with severe lupus nephritis at increased risk for progression to end-stage renal disease. Maintenance treatment is with mycophenolate or azathioprine. Rituximab may be considered in refractory or relapsing disease. calcineurin inhibitors may be considered second-line agents for induction or maintenance therapy, mainly in membranous lupus nephritis, podocytopathy, or proliferative disease with refractory nephrotic syndrome despite care. In refractory cases, calcineurin inhibitors may be combined with MMF, SLE in pregnancy. The incidence of spontaneous abortion, premature labor, early preeclampsia/eclampsia, fetal growth restriction, and intrauterine death are somewhat higher in women with SLE. When treating pregnant women, hydroxychloroquine, corticosteroids, low-dose aspirin, and azathioprine are generally safe. Mycophenolate, methotrexate, and cyclophosphamide are contraindicated in pregnancy. Cyclophosphamide should be stopped 3 months before attempting to conceive, and both men and women receiving cyclophosphamide should be on appropriate contraception. High-dose aspirin and nonsteroidal anti-inflammatory drugs, NSAIDs, should be avoided in later pregnancy. Egg harvesting or sperm banking should be considered before treatment. Neonatal lupus erythematosus, NLE, can develop due to transplacental passage of specific maternal autoantibodies anti-Rho and anti-La. Neonates can present with rash around 4 to 6 weeks of life, elevated liver function test results, thrombocytopenia around 1 to 2 weeks of life, neutropenia, and hydrocephalus. In most cases, the symptoms of neonatal lupus disappear spontaneously by 3 to 6 months of age. NLE can also manifest as a congenital atrioventricular conduction block, which is permanent. If you or someone you know is living with SLE, it's crucial to work closely with a healthcare team to manage symptoms, monitor for complications, and make lifestyle adjustments that promote overall well-being. Remember, early diagnosis and proactive management play a key role in achieving better outcomes. If you found this video informative, please give it a thumbs up, share it with others who may benefit, and don't forget to subscribe for more health-related content. If you have any questions or topics you'd like us to cover in future videos, feel free to leave a comment below. Thank you for joining us today, and until next time, take care of your health and stay informed.